Very much, and thank you for allowing me to talk a little bit earlier. So it's you've heard the presentation by Spargias about the TMVR parade and the challenges. This is our work. This is the live-in-a-box case of the Alta valve. We were privileged enough to do the first in man of the new iteration, the 29 French low profile, and a few words about the patient. This is an 82-year-old female with severe mitral regurgitation, degenerative, NYHA class 3, some renal impairment, NT-proBNP elevated, unobstructed coronary, severe pulmonary hypertension. You can see that it's a post-capillary and mainly, but there is some elevation of the pulmonary vascular resistance, and naturally the Euroscore 2 is quite high on this patient. I have a few clips of the echo. So this is a prolapse. It was a P2, but also a P3 prolapse. And this is why that made a limited suitability for a TEER. There's, without any doubt, severe mitral regurgitation. Regurgitation fraction was estimated by the echo core lab 54%, ERO 50 square millimeters. You can see the prolapse, practically the whole medial part of the valve is prolapsing. And that made us a little bit worried whether we would be able to achieve a good result. And the RV function is good, though. The LV function is also maintained with an ejection fraction of 64%. And the aortic valve is nice. And there is a significant tricuspid regurgitation. It was deemed moderate plus, not severe. This patient, and the estimated systolic pressure on the echo was 76, but the invasive catheterization showed a lower ejection fraction. This patient was recruited for the early feasibility study of the Alta valve. We have done 7 cases out of the 15 so far in our center. And exclusion criteria is severe TR and severe pulmonary hypertension, but this patient borderline missed this criteria. So this is the implant. Spargias showed it later. It's very interesting. There is a cage, which is a nitinol stent frame that is passively opposed against the left atrial wall. There is an oversizing about 10 to 15% in width and about 5 to 10% in height. The bottom part of the implant is an annular ring that conforms almost 1-to-1 ratio with a native annular ring. And there is a PET skirt that mitigates PVL. So the valve itself is sitting in the center of the implant. It's a bovine pericardial valve, 27 millimeters. It's the same size for each implant. And as for most designs, current designs, this valve is also a dual stent frame design. So the outer stent frame conforms to the native anatomy. The inner frame is the valve. So the valve should be not disturbed in its functional anatomy by the interaction with the native anatomy. The top part of the valve is the cap where the delivery system is inserted. And of course, this is a transfemoral transeptal system. The workup that we do, apart from the echo that I just showed you, is a CT workup that looks at the annulus. So you can see the annulus here, but also to the left atrial size, width and height. And we choose the implant based on the annular and the left atrial dimension. So the left atrial cage, the nitinol stent frame, is personalized for the patient, but the annular frame comes to 3 different sizes, 40, 46, and 54. And this patient was actually very interesting. It was the big one. It was 54. And 54, as you know, doesn't come out in many technologies. In fact, I'm not sure if there's any at the moment that can produce a 54 annular ring. So this is a big valve, and this is a big challenge. So the procedure that I'll show you comes at a single stage. So it's one-stage procedure, 4 steps. So first we obtain transeptal access. We aim for an inferior and posterior position. This is the best way to avoid coming parallel to the aorta, aortic hugging. Then the steerable guide catheter comes into the position. This is 29 French. And through that, the delivery system, you can see at the bottom here, the catheter has got a single steerability feature that flexes down to the valve via this knob. And this is the delivery system that goes in. And this has the implant at the tip of that. And then we flex down to the valve at the second stage here. Once we're happy in position, we deploy the valve from the annular ring to the top of the cage. And then once we're happy, we release. If we're not happy with the position, we can always recapture and reposition as necessary. The valve is also fully recapturable with a big question mark about the 54 annular ring. This is too big, and at the moment we're not 100% sure we can fully recapture. But we can certainly partially recapture and reposition this implant. So this is the case. This is live case. So we start with the transeptal puncture. You can see here standard equipment for that. And this is the puncture, which is done posterior. And there on the bicable view, you can see this is an inferior puncture. So we obtain access to the left atrium. The approach was done via cut-down because this is 29 French, and we were a little bit concerned at the initial stages of this journey to make sure that we have full access. So there's cut down, but over the last 3 cases that were done in the US, these cases were performed fully percutaneous, so this is absolutely doable. The next step is to perform a balloon septostomy. So a 12-millimeter balloon will be used here to inflate and create some space in the septum to accommodate the passage of the sheath. So this is the septostomy here. You can see the balloon. There's some indentation, and we can see that on the TEE, the presence of the balloon. And we leave the balloon up sometime in order to accommodate smooth dilatation of the septum. We don't want to tear the septum. We want to gradually open that. This is how we can avoid problems. And now you can see the steerable sheath being inserted. This is the sheath over a standard Amblat supersteve wire. This is a straight sheath, and we can observe that passing through the septum here and here. We will connect it to our stand in a similar way we do with the mitral clip. This is the stand. And we take the dilator and the wire out. So the sheath, you can see that is in position. And now you see the delivery system that goes through the sheath. So the first step is to secure the relative position of the 2 catheters on the table with this stand that we use. Forgot to mention that we have continuous arterial pressure monitoring. We have LV monitoring to observe the LVOT gradient instantaneously. And in this particular patient, because the cardiac index was borderline 1.8, we put an intra-aortic balloon pump because, as I mentioned earlier, TMVR can create an acute afterload mismatch, and balloon pump is actually quite useful, as well as very nice management of the inotropes on the table. So now the plan will be to bend this system down to the mitral valve. You can see we flex the catheter and we bend down to the mitral annulus. We work in a pre-specified view, an RAO cranial usually, or RAO caudal, depending on the CT scan. You would expect the annulus to be around here. If there is some calcification of the annulus, this is great news because you have a fluoroscopy marker. But in this case, there wasn't. So this valve is meant to work both for calcified annuli and for non-calcified annuli. We observe, of course, the flexion of the catheter on the echo. So the echo is our eyes again. It's very important to emphasize that. And we use 0 contrast for this implantation. So now we're down to the valve, and we have our reference with commissural and the perpendicular X-plane view, the long axis view. We want to be in the center of the anatomy, so the valve has to be in the A2P2 region, and we want the tip of our implant to be at least relative to the lateral part, 10 to 15 millimeters. So this is 12 millimeters measured now by Elias, and we measure again, this is 14, 16 millimeters, so we're happy that this is a nice position to start deployment the implant, starting from the annular ring. You can see the hemodynamics, you can see how the valve looks in position. We start the deployment very, very slowly by using this knob to deploy the inner part of the valve. So you can see now how the annular ring gradually deploys here, there, like a bulb. And we observe very slowly our position. We don't want to go up, but we equally don't want to dive in. We're happy with our trajectory because our trajectory is quite perpendicular to the level of the valve. We don't hug the aorta. So now we're moving back. There's a dual catheter design, so there is an inner catheter that goes back first. And once we're happy with the position, then the guide catheter, the steerable guide catheter, also is retrieved back. Once we have deployed the bottom part of the implant, here you can see this is the chimney. The chimney is in there. It's still cinched. There's an internal catheter, 6 French, which we call the positioner, that has a snare around the chimney. And
so, Vlasi, at this point, is it retrievable?
Oh, absolutely. It's retrievable up until the end.
Okay, good.
May I say repositionable, because retrievals, you can take it out. 54, I'm not sure if you can take it out. We've never had to. 40, 46, we have taken it out on one occasion, but 54, you're committed to implanting this valve one way or the other. This is the valve itself, and you can see this black thing is the inner catheter that goes internally outside the chimney of the valve, and there's a snare around it. This we call the positioner, and this is a feature that wasn't there in the first iteration that keeps the valve in position while implanting it. And it's a very useful feature, actually. But we always want to engage the implant laterally. So this implant is touching the lateral commissure of the mitral valve, as you can see here, and that gives extra stability. And at the same time, we are pacing so that we maintain our position, because there's always annular motion, and this annular motion could disrupt the implant. You may have pop-outs as you are deploying the cage. So we always verify the position, we verify the hemodynamics, and now we are in the position to slowly deploy the cage. We want this cage to be deployed and touch the wall of the left atrium. This is our security. This is what will stabilize the implant in place. So slowly and steadily, we are withdrawing the catheters, and this slowly you should see this cage being deployed. In that particular moment, we have loosened the snare of the implant. So you can see now the footprint of the chimney is increased. Now the valve is fully functional. You can see even on the TEE that the leaflets are moving. And usually that is enough to preserve the hemodynamics of the patient, because you have a fully functioning valve, and at the same time you pretty much seal the annular ring, the annulus, the native annulus. So it's a process. We take our time. We don't rush. We don't want to take too long, because we want the cage to open and touch on the left atrial wall. See now, this cage is opening. But at the same time, we want to maintain our position. We don't want to dive too deep or go too high. And in the end, the beautiful thing about this valve is that it will take its shape and place, and it will self-center. Oops, have I done something wrong? Probably I have. Give me 1 second. So, as we move on, you can see that we're gradually deploying the cage now. We're almost there. You can see the cage now opening in the left atrium. So we're using the knobs to deploy that. So internal catheter goes back to the fossa. External catheter will follow. You can see the LVOT is widely open. I'll just accelerate that for the interest of time. And this is it. So now the valve is in position there. You can see the cap. We're just pushing it out to make sure that it takes the position. And now you can see on the left the struts of the nitinol stent frame almost touching the left atrial wall. The valve is in position. There's no PVL. And the LVOT is widely patent. What?
I mean, if you have to re-engage the handles,
Yeah.
even with these sides, you said you cannot completely.
You can go all the way down to the chimney. So, for example, all this Ninios stent frame you can resheath. You can go all the way down to the valve. You can recinch the valve, so you can reduce the footprint. And then you can reposition if necessary. For example, it pops out. You can get it 90% inside the catheter, and you can re-engage to the annulus so that you can use another position. Or if you have dived too deeply in, you can pull up like that. So all this structure you can resheath up until deployment. Now the valve is deployed. You can see here the attachment. This is the ring. I'll just go back a little bit because we missed. Here is. Yeah, and hemodynamics. So you've got continuous monitoring of the LV pressure and the aortic pressure. Of course, here the LV pressure is a bit lower than the aortic because you have the balloon pump offloading your LV. So that's an interesting thing that we found. But the main thing is to make sure that you don't have any gradient, any LVOT obstruction. If you have, because say, for example, you have a scenario that your blood pressure drops in the middle of the implantation. You don't know if that's due to afterload mismatch or acute LVOT obstruction. You have to be able to instantly see these hemodynamic parameters. The treatment is totally different in this situation. So here we had a little bit of a blood pressure drop. We gave some adrenaline to help the ventricle, and within a few minutes, patient recovered. Because once you eliminate the MR, the ventricle will take a hit. So this is the final position of the implant. We do all the hemodynamics checks. So this is the gradient. The gradient in the mitral position is 1. You can see the LVOT is widely open. There's no PVL. There's 0 PVL. And you can see all the smoke, of course, in the left atrium that you'd expect. You see that with MitraClip. When you eliminate the MR, there is always smoke. But here is the MR. There's no MR. There's no gradient. There's laminar flow throughout. And one thing that we check is the ASD, the residual ASD. We tend not to close this unless there's a right to left shunt. Here we had a left to right shunt, so we were happy. Of course, if it's too big or if the patient already had some right ventricular dysfunction or tricuspid regurgitation or pulmonary hypertension, like this case, you may think twice and reevaluate or bring the patient back if the patient has decompensated features. This is how it looks on 3D. You can see this is the ventricular end, and there was the atrial end. And this is the end of the case, pretty much. Thank you very much.
So, Vlas, this is an amazing case. I'm sure maybe you will lose your plane, right? But can you... Okay. So we have a couple of questions, but before Ted and Nikos and Peter do your questions, I have two considerations. One is thrombotic consideration, because you have a big cage inside the left atrium, which is very big. I suppose this is pre-thrombotic condition, and also I have tilting considerations. Maybe how do you anchor this valve? How do you make sure that you're in the right place? And of course you check with the TOE, but maybe you have some tilt in the valve. How do you get away with it?
Very, very good questions. First question, we recommend formal anticoagulation with warfarin, as for most bioprosthesis in the mitral position, for 6 months. There is animal studies to suggest that the struts endothelialize when they are opposed against the left atrial wall, and then the implant is just a bovine tissue valve which shouldn't have any problems. So far, the longest follow-up of the transapical cohort, because half of the population treated so far is transapical, but of course the tendency is to move transfemoral with the low-profile system, showed no evidence of thrombosis of the valve or the cage inside the left atrium, no embolic events, 0 strokes. Our longest follow-up now is since April last year, So it's almost 14, 15 months, and we didn't have any problems. The second question, the valve self-centers. Now, what we found, and this is unique because nobody has actually implanted such a big footprint implant in the left atrium ever. I mean, we have ASD devices, we have Watchman devices or LAA closure devices. This is a big cage in the left atrium. But what we found out is that there's always an anterior tilt of the left atrium. So the roof of the left atrium is always tilted anteriorly. So what that means is that the valve is taking a natural anterior tilt. So the bottom part of the valve, the annular ring, is always deeper in the A2 area and more superficial in the P2 area. And that gives an axis which is parallel to the LVOT. And there is work in progress now. Joao Cavalcante from Minneapolis Heart is working on that on CT data. In systole, this valve has got the unique feature that the LVOT diameter is actually increasing as opposed to decrease because the implant and the opposing ventricular septum are moving away from each other. And that has implications with the flow pattern throughout the ventricle, the inflow. But this is work in progress. This is early days. We don't have many implants, but these are some interesting features.
Yeah. Nico Spilias from Cleveland Clinic. So, Nico.
Thank you very much. Great case and interesting new technology. My first question was about the anticoagulation plan, and you covered that 100%. I know it's kind of early in the process, but my other thought was that what about future transeptal access or feasibility of valve-in-valve in the future? What are your thoughts on that?
It's another excellent question. The strut opening of the cage can accommodate 24 French. And in fact, on 2 patients, we have to close the residual ASD. So we had to go back in, and we just put an ASD device, no problems. You can easily pass a TAVI, balloon expandable, for example, TAVI. And the chimney is annular at the bottom, supraannular at the top. So valve-in-valve, this is a 27 millimeter internal diameter. The label is the same, like Dr. Kofidis valve. So there's no cheating here. So you put the valve there for 27 millimeter, which you can easily put because you don't obstruct the LVOT. You're sitting high up inside the left atrium. And they've all done in animal, it's all happened in animal models.
So, Dr. Kapitein.
Yeah, no, Vlas, I had the privilege of observing a case and really impressive.
But this is the actual case, by the way.
Yeah, how you did it. So really, really well done. So could this valve also work in a tricuspid position? And if you think so, how would we handle either pacemaker wires that are already in the patient or future pacemaker wire implantation?
Well, there are thoughts to move to the tricuspid position with, of course, design changes, and the engineers are working on that. I'm not here to say anymore. I don't know is the answer. Certainly, like most of the TMVR technologies that are being tested, the wires, like even with TriClip, the wires are always a problem. I guess for most technologies like, for example, trick valve, you can trap the wires without any problems. Now, I'm not sure if you put a full cage inside the left atrium and you push all the wire out, what will happen? But that never happened so far. It's, of course, a very interesting question.
But there are thoughts to move to the tricuspid. Yeah, interesting. And Theo, one more question.
Well, this is excellent case, and we are learning a lot from you, especially these new technologies. I think the superiority of this valve is a supraannular design. So can we also say that this valve is a supraannular mitral valve? Because there is no interaction between the annulus, but surgeons know that when they take the annulus, because the annulus is a saddle type, there are some hinge points, which is the development of the also mechanism of paravalvular leak. So what about the results of your follow-ups? Is there any problems about the interaction between the annulus?
Well, that is the question that we're trying to answer now, observing the CT follow-up of all the patients that we performed transapical and transfemoral. The valve, I mean, the implant is supraannular, but the engagement is at the level of the annulus. So you have to go 10, 15 millimeters below. The initial implantation that was done by Philippe Généraux in Morristown was supraannular. There was a ball inside the left atrium, and they found out that actually you cannot center it. So you have to engage in the annulus. Now, at the annular level, this valve is 1-to-1 ratio. It's not oversized, but what we found, and this is preliminary data, is that the annular dynamics are preserved. Now, what is also interesting, there is the PET skirt, as you saw, that prevents PVL. But you have also the native leaflets functioning. So the native leaflets are actually working as an active sealing skirt, similar to the one that the current TAVI designs have, that they inflate in diastole. These they seal in systole. Of course, you have the commissures, and these are sensitive areas that you may have a PVL. Generally, PVL, in these cases that we have seen, is the worst case scenario is mild PVL. If the valve is positioned correctly, you only get mild PVL.
I have a quick question. Vlasi, congratulations on your pursuit of this technology, really pioneering work. I really enjoyed watching this excellently executed case and also the selection of the patient. It looked from a surgical standpoint, perfectly selected atrium for this particular valve. Now, I guess this valve anchors primarily through, if not radial, it's a nitrinal frame, through circumferential stresses. What will that do to a functional left atrium that now will turn dysfunctional? And do you plan to compare atrial fibrillation patients versus sinus rhythm patients in the future?
Another excellent question, especially as modern surgery that you are performing endoscopically focus on atrial fibrillation, ablation, and LAA closures. So we have to think about all these things. Luckily, most of the patients recruited so far, 80% have some form of atrial fibrillation, either paroxysmal or persistent. You would expect patients with that burden of pressures on the left atrium to have some degree of AF. But 20% of these patients that we have treated so far actually had sinus rhythm on baseline ECG, and we haven't seen any AF evidence before or even after the procedure. And the CT follow-up shows that not only do you preserve the annular dynamics, but there is also wall motion of the left atrium. And another interesting thing that we observed recently is that you do have an oversize of the cage by 10 to 15%, especially on width. But the actual distension of the left atrial wall you get is no more than 2%. So this left atrial wall that we all know, you know better than us, that is very thin and compliant, is actually not as compliant as we think. It's actually maintaining its motion. Work in progress.
Okay, thank you, Vlasi. Greg, do you have any final comment before we let Vlasi go?
Not really. This is impressive work. Congratulations, Vlasi. It's clearly work in progress, and it seems to be a very promising valve, I think. Great work.
Okay, good. So thank you, Vlasi. So we have to move on.